Hello friends, welcome to Creative Medicine. In this lecture, we will learn about Hello friends, let us now learn some important points about Gallstone Ilias. So, this Gallstone Ilias is most commonly seen in elderly patients who is more than 70 years of age. So, this is having only one large single stone can also result in Gallstone Ilias. So it is asymptomatic. Most common site of fistula of Gallstone Ilias, fistula that can occur due to this is cholecystoduodenal fistula can occur, and second most common site of fistula is cholecystocolic fistula. Most common site of fistula is cholecystoduodenal fistula. Second most common site of fistula is cholecystocolic fistula. Cholecystoduodenal fistula and cholecystocolic fistula. Most common site of fistula is cholecystoduodenal fistula, and second most common site of fistula is cholecystocolic fistula. Then we have pathology. In pathophysiology, there is a large stone in the gallbladder. This large stone causes inflammation and erosion of the gallbladder, and this inflammation and erosion of the gallbladder leads to the fistula formation between the gallbladder and the duodenum. There will be a formation of fistula occurs. Now, the stone moves from GIT and causes obstruction in the narrow. The stone has passed from the GIT, from the gallbladder into the duodenum. From the duodenum, it goes to the ileum and it gets obstructed in the terminal part of the ileum. Okay, so this will result in small bowel obstruction. This will cause small bowel obstruction with ectopic gallstones, and it results in pneumobilia. Small bowel obstruction with ectopic gallstones and pneumobilia will be the Rigler's triad. Small bowel obstruction, ectopic gallstones, and pneumobilia. Together we call it as Rigler's triad. Now, if you see the signs and symptoms of small bowel obstruction, so because of the small bowel obstruction, the patient will develop colicky pain, multiple episodes if bilious vomiting, and non-passage of feces. The patient will develop colicky pain, multiple episodes if bilious vomiting, and non-passage of feces will occur. Diagnosis is on X-ray. You will see presence of dilated loops. So on X-ray, you will see presence of many dilated loops will occur with multiple hair fluid levels will be seen. And on ultrasonography, you will see that the gallbladder is empty and it presents there will be air in the gallbladder. Normally, you will not see air in the gallbladder, but here gallbladder is empty and detects the presence of air. So how are you going to treat this patient? Treatment is you will have to do enterotomy. Treatment is you should do enterotomy and you should remove the obstruction. You should do enterotomy and you should remove the obstruction in this case. Cholecystectomy is preferred only in young and stable patients. This is calculus. This is about Gallstone Ilias, which is a complication of Gallstone Ilias. Then the next important is acalculous cholecystitis. In acalculous cholecystitis, here there is an inflammation of gallstone in the absence. There is inflammation of the gallbladder in the absence of gallstone. There is inflammation, but there is no gallstone. That is acalculous cholecystitis. In this, two factors are responsible. One, it is due to gallbladder stasis. That is, the bile is present in the gallbladder, and here there will be stasis of bile. Second, it can be due to gallbladder ischemia. That is, the blood supply to the gallbladder has been lost. So, gallbladder stasis and gallbladder ischemia will result in acalculous cholecystitis. Now, if you see the risk factors are it can be due to prolonged fasting or prolonged total parenteral nutrition requirement. Number one, it can be due to prolonged fasting or prolonged total parenteral nutrition requirement, or prolonged hospitalization can result in this, or prolonged ICU stay, and also prolonged long duration surgeries like coronary artery bypass grafting, total hip replacement surgery, and also in massive burns. So what are the conditions predisposing to acalculous cholecystitis? They are prolonged fasting, prolonged total parenteral nutrition requirement, prolonged hospitalization, prolonged ICU stays, long duration surgery like coronary artery bypass grafting, and total hip replacement, and massive burns. So all these are mainly predisposing factors. Next, if you see the investigations, the investigation of choice is actually ultrasonography for acalculous cholecystitis. And if you see the gold standard here is HIDA scan is gold standard. So investigation of choice is ultrasonography and gold standard is HIDA scan. Now if you see the treatment is we have laparoscopic cholecystectomy. Laparoscopic cholecystectomy is actually the treatment of choice. Then, but for unstable patients, it is for stable patients. Laparoscopic cholecystectomy is the treatment of choice. But if you see for unstable patients, the treatment of choice for unstable patients is percutaneous cholecystectomy. Treatment of choice is percutaneous cholecystectomy is the treatment of choice for unstable patients. Next we have something called as gallbladder polyp. So in gallbladder polyp, we have two things. One, we have cholesterol polyp. In gallbladder polyp, we have cholesterol polyp. Second, we have adenomatous polyp. One, we have cholesterol polyp. Second, we have adenomatous polyp. Cholesterol polyp is most common and it is small and multiple, which are 10 millimeters, less than 10 millimeters, and they are multiple. Most common cholesterol polyp is most common, less than 10 millimeters, and there are multiple polyps which are benign, and pedunculated polyps are seen, which are cholesterol polyps. Then we have adenomatous polyps. In adenomatous polyps, they are actually less common and they are large single polyp. They are large single polyp and they are pre-malignant and sessile polyp. So cholesterol polyps are most common, less than 10 millimeters, small, multiple polyps and benign pedunculated. Whereas adenomatous polyps are less common and they are large single pre-malignant polyps and they are sessile polyps are called as adenomatous polyps. Now if you see the factors which increase the risk of invasive cancer in adenomatous polyp. So factors which increase the risk of cancer in adenomatous polyp are, so age more than 60 years will increase the risk of invasive cancer in adenomatous polyp, or if there is presence of gallstones, or if the size of polyp is more than 1 centimeter, or if size of polyp is more than 1 centimeter, or if there is documented increase in size. So increase in size on repeated scans. Documented increase in size on repeated scans. So all these are the factors which increase the risk of invasive cancer in adenomatous polyps. What are they? Age more than 60 years, the presence of gallstones, size of the polyp more than 1 centimeter, documented increase in size on repeated scans. So all these will increase the risk of invasive cancer in adenomatous polyps. Then the second important thing which we have is strawberry gallbladder. So first, in the strawberry gallbladder, you will see this strawberry gallbladder is also called as cholesterosis. What do you see in cholesterosis? Here there is deposition of cholesterol esters occurs and triglycerides occurs in the epithelial macrophages. So in the gallbladder, in the epithelium, there will be macrophages. These macrophages will cause deposition of triglycerides will occur, or cholesterol esters will occur. Deposition of triglycerides and cholesterol esters occurs in the gallbladder, in the epithelium, in the macrophages of the gallbladder. So this is strawberry gallbladder. So the strawberry gallbladder is actually an acquired condition which has hypercholesterolemia. Acquired condition with hypercholesterolemia, and also there is presence of cholesterol stones will be seen in the gallbladder, and also in the gallbladder you will see presence of cholesterol polyps will also be seen here. So in strawberry gallbladder, that is also called as cholesterosis, and here it is caused by the deposition of cholesterol ester triglycerides in the epithelial macrophages of the gallbladder, acquired condition with hypercholesterolemia, and there is presence of cholesterol stones and cholesterol polyps occurs. The main treatment of this strawberry gallbladder is, you will see, laparoscopic cholecystectomy is seen in these patients. Then we have something called as adenomyomatosis. What is adenomyomatosis? Adenomyomatosis is actually characterized by hyperplastic changes which occur in the gallbladder wall. So as a result, there will be mucosal hyperproliferation occurs, and as a result, the mucus deposition will occur in the gallbladder. So if you see the diagnosis on ultrasonography, there will be a sign called as diamond ring sign is seen. On ultrasonography, you will see presence of diamond ring sign will be seen, and this diamond ring sign is also called as comet tail artifacts. This diamond ring sign is also called as comet tail artifacts, or also called as V-shaped artifacts. These are called as comet tail artifacts, and V-shaped artifacts are said. That is adenomyomatosis. So if you see the treatment, in the treatment we have laparoscopic cholecystectomy is seen in these patients. Next we have something called as porcelain gallbladder. So in the porcelain gallbladder, this is also called as calcified gallbladder. It is porcelain gallbladder or it is calcified gallbladder. So in this, it is characterized by excessive calcium incrustation in the gallbladder wall. And on surgery, if you see, the gallbladder is actually bluish in appearance and it is also brittle in consistency. Gallbladder is bluish in appearance and it is brittle in consistency is noted. And most of the patients are actually asymptomatic. And it is seen mainly in the 5th to 6th decade of life. And more than 90% of the patients have gallstones. So in porcelain gallbladder, more than 90% of the patients have gallstones. It is seen in 5th to 6th decade of life. And generally diagnosed incidentally on X-ray or CT scan. Diagnosed on X-ray or CT scan. Then we have carcinoma gallbladder. So in carcinoma gallbladder, smoking is not a risk factor for carcinoma gallbladder. So what are the risk factors for carcinoma gallbladder? The risk factors include Cholidocal Cyst, and we have obesity is a risk factor of carcinoma gallbladder. Then we have gallstone of more than 3 centimeters, primary sclerosing cholangitis, and adenomatous polyps, and also chronic typhoid carriers. Chronic typhoid carriers. So then we have porcelain gallbladder. Porcelain gallbladder. So all these are the risk factors of carcinoma gallbladder. They are cholidocal cyst, obesity, gallstone more than 3 centimeters, primary sclerosing cholangitis, adenomatous polyp, chronic typhoid carrier, and porcelain gallbladder are the risk factors of carcinoma gallbladder. Then the maximum incidence of carcinoma gallbladder, maximally it is seen in India, followed by Pakistan. So in India also it is most common in Uttar Pradesh more than Bihar. Then it is most commonly seen in females in around 6th to 7th decade of life, and it is also the most common site. If you see, it is most commonly seen in the fundus of the gallbladder. That is almost 60% of the cases you see in fundus of the gallbladder, followed by body in 30% of cases, followed by neck in 10% of cases. So if you see carcinoma gallbladder, it is most commonly seen in the fundus of the gallbladder, that is 60%, followed by the body of the gallbladder in 30%, followed by the neck of the gallbladder in 10%. Then we have carcinoma gallbladder and cholangioma. So if you see carcinoma gallbladder versus cholangioma, so both this carcinoma gallbladder and cholangioma, both these are actually adenocarcinomas, and then both these have CEA specific marker, and it has CA 19-9 is also a specific marker. So both these will have carcinoembryonic antigen and CA 19-9. Carcinoembryonic antigen is actually a non-specific marker, whereas CA 19-9 is actually a specific marker. Then chemotherapy regimen for both of these is gemcitabine with cisplatin is the chemotherapy regimen. Gemcitabine with cisplatin is the chemotherapy regimen for both carcinoma gallbladder and cholangioma. Then if you see the histopathological types were also same for this both carcinoma gallbladder and cholangioma. So the histological regimens include diffuse infiltrative or sclerosing variety, then we have nodular variety, then we have papillary variety. So the main histological types are diffuse infiltrative or sclerosing variety, nodular variety, and papillary variety are important histological types for carcinoma gallbladder and cholangioma. Then if you see the important points, if you see what is the most common route of spread of carcinoma gallbladder, it is that the most common route of spread of carcinoma gallbladder is direct hepatic invasion is the most common route of spread. And then this carcinoma gallbladder have gallstones. Gallstones are present in approximately 75 to 98% of cases. And gallbladder stone patient will develop carcinoma gallbladder. The patient will develop carcinoma gallbladder in 0.3 to 3% of cases. And even if you see large stones are also at risk of developing carcinoma gallbladder. They are also at risk of developing carcinoma gallbladder, or large stones which are more than 3 centimeters are also at risk of developing carcinoma gallbladder. Then if you see the clinical features, in the clinical features there is a repeated attacks of biliary colic are seen. There are repeated attacks of biliary colic are seen which are associated with increased frequency of the attacks, and increased severity of pain. There is increased frequency of attacks and increased severity of pain in these patients. And here there is sudden change in character of the pain will also be there. Character of pain will also change with anorexia and weight loss will be seen. Okay, there will be sudden change in character of pain with anorexia and weight loss will be seen. So if you were asked what is the first investigation which is done is ultrasonography, then investigation of choice for carcinoma gallbladder is CECT. In CECT, the gallbladder wall is thickened and it is associated with gallstones. The gallbladder wall is thickened and it is associated with gallstones. This gallbladder is actually replaced by a mass. This mass is nothing but the growth which is arising from the fundus and it is protruding into the lumen. So the mass is nothing but the growth which is arising from the fundus and protruding into the lumen is also seen. It can be seen in CECT, and you can also see presence of lymph nodes can be seen in CECT, and ascites may or may not be seen in CECT. Okay, so these are the main investigations. Then if you see the staging, in staging we have stage 1A. Stage 1A is involvement of lamina propria is stage 1A. Stage 1B is involvement of muscularis mucosa is stage 1B. Lamina propria is stage 1A, T1A, whereas T1B is involvement of muscularis mucosa is T1B. Then invasion of perimuscular connective tissue towards the peritoneal site is T2A. There is perimuscular connective tissue. It is muscularis mucosa. Now T2A is around the muscular connective tissue. So this is mucosa. Here you will have submucosa. Then you have muscularis mucosa, and finally you will have serosa. Here there will be involvement of perimuscular connective tissue will be involved. Perimuscular connective tissue will be involved towards the peritoneal side, but there is no involvement of serosa in these patients. Without involvement of serosa, there is invasion of perimuscular connective tissue towards the peritoneal side without extension to serosa is seen in T2A. Okay, then we have T2B. Then T2B is invasion of perimuscular connective tissue towards the hepatic side without direct hepatic invasion. So it is invasion of perimuscular connective tissue. Here there is invasion of perimuscular. So if this is connective tissue will be perimuscular connective tissue will be involved without the involvement of hepatic side. So that is stage 2B. Then we have T3. In T3 there is serosal proliferation with direct hepatic invasion. There is either invasion into the liver, or there is invasion to the serosa is seen. So there is either invasion into the liver or there is either invasion into the liver is seen. That is T3. Then we have T4. In T4 there is involvement of portal vein or hepatic artery or two or more extrahepatic origin is seen. So here there is involvement of portal vein is seen, or there is involvement of hepatic artery is seen. This is T4. Okay. Then we have N1. N1 is metastasis to 1 to 3 lymph nodes is N1. Then we have N2. N2 is metastasis of 4 or more lymph nodes is N2. Then we have M0. M0 is no distant metastasis. M1 there is distant metastasis is present. So this is the staging of carcinoma gallbladder. Then based on the staging we have to see the treatment. So if the patient is T1A, we can do laparoscopic cholecystectomy can be done if the patient is T1A. If the patient is T1B, T2A, T2B or T3 or T1 to 3 N1, then in all these we can do extended cholecystectomy is done. Okay, if the patient is T1B, T2C, T2B, T3, T1, 2, 3 and N1, you can do extended cholecystectomy. If the patient is T4, N0 to 1, then you should do again extended cholecystectomy is done, and also you can also do extended right hepatectomy can be done. Extended cholecystectomy and extended right hepatectomy is done for T4, N0 to 1. Then if it is any T and N2 is present, or if T is any or N is any, and if there is M1, in such cases you should give palliation therapy only. If there is any T and N2, or if there is any T, any N or M1, then you should go to palliation therapy only. Then we have extended cholecystectomy. So if you see in extended cholecystectomy, there is en bloc removal of segment 4B and segment 5 of the liver and gallbladder and lymph node. there is en bloc removal of segment 4B and 5 of liver and gallbladder along with lymph node. Along with the cystic duct, we will also remove the cystic duct, and we will remove the common bile duct, and also we have to remove the periportal and retroportal tissues also. Now, in a patient with gallstone disease, laparoscopic cholecystectomy is performed, and once you have taken the specimen, you have done the laparoscopic cholecystectomy, and then you will get the specimen, and this specimen is taken to the pathological lab. Report comes back positive for adenocarcinoma. Once you have taken it to the pathological lab, it comes positive mainly for anything that it has come positive for adenocarcinoma. Then you will have to do a treat. You will have to. So because the patient is performed, the patient has gallstones. You have done cholecystectomy and you have sent the specimen, and it is positive for adenocarcinoma. Then in such case, you should have to do. Observation should be done, and you should do follow-up. You should observe the patient and you should do follow-up of the patient. Because laparoscopic cholecystectomy is already done, so you do not need to do anything in this patient. Then we have stage 2. If the patient is stage 2A, or if the patient has T2A, if the patient has stage 2A and T2A, then what will you do? Now if you have already done laparoscopic cholecystectomy and for gallstone release, and you have removed the gallbladder and you have sent it for examination, pathological lab for examination, and you have found out that it is stage 2A or stage T2A. Now what do you do? Now you will have to do extended hepatectomy. You should have to complete the extended cholecystectomy. Sorry, you should do extended cholecystectomy in this case. Port site excision can also be performed. You can do extended cholecystectomy, and port site excision is also performed in these patients. There is no survival advantage is seen. Only prognostic importance is seen for this, but no survival advantage. Then if you see first, what is the first laparoscopic cholecystectomy which is performed? First laparoscopic cholecystectomy performed is Eric Muhe is the first laparoscopic cholecystectomy performed. Then if you were asked what is the first video assisted laparoscopic cholecystectomy performed, it is Philip Moret is the first video assisted laparoscopic cholecystectomy performed. Then if you were asked what is the first lap appendicectomy performed, it is actually Kurt Sem, who is the father of pelviscopy, is the first pelviscopy, is the one who has done first laparoscopic appendicectomy. So first laparoscopic cholecystectomy was Eric Muhe has done the first laparoscopic cholecystectomy. First video assisted laparoscopic cholecystectomy was performed by Philip Moret. First laparoscopic appendicectomy is performed by Kurt Sem, and Kurt Sem is also called as father of pelviscopy. Then we have something called as bile duct. Now anatomy of the bile duct. So in the bile duct we have first common hepatic duct. Okay, common hepatic duct length is 1 to 4 millimeters, and diameter of common hepatic duct is 4 millimeters. So right hepatic duct and left hepatic duct combine together to form common hepatic duct, which combines with cystic duct to form, this is common hepatic duct, and then this will form common bile duct. Okay, now for the common hepatic duct, the length is 1 to 4 centimeters is the length of common hepatic duct, and the diameter is 4 millimeters. Okay, then if you see common bile duct, in common bile duct the length of the common bile duct is 7 to 11 centimeters, whereas the diameter of common bile duct is 5 to 10 millimeters. So length of the common bile duct is 7 to 11 centimeters, and diameter of common bile duct is 5 to 10 millimeters. Now, if you see the blood supply, in the blood supply we have supraduodenal bile duct. So supraduodenal bile duct will get blood supply from two regions. One, it gets blood supply inferiorly, that it is at 60%. If in 60% of cases it gets blood supply inferiorly from, it gets blood supply from pancreatic duodenal artery, and then it also gets blood supply from retroduodenal artery. It gets its blood supply from pancreatic duodenal artery and retroduodenal artery. Superiorly, supraduodenal bile duct, inferiorly from supraduodenal bile duct gets good blood supply. So it gets good blood supply inferiorly from pancreatic duodenal artery and retroduodenal artery, and also superiorly from right hepatic artery and also the cystic duct artery. Right hepatic artery and cystic duct artery are the main important things. Next, it also has coaxial blood supply. Coaxial blood supply these are actually present in 3 o'clock position to 9 o'clock position. We have this coaxial blood supply. Hence, if there is longitudinal incision is given in bile duct. So because the blood supply is from 3 o'clock position to 9 o'clock position, we give a longitudinal incision is given in the bile duct. Next we have sphincter of Oddi complex. Sphincter of Oddi complex, if you see this sphincter of Oddi complex, it has number 1 we have sphincter ampullae, and then we have sphincter pancreaticus, sphincter ampullae, sphincter pancreaticus, and we also have superior cholidocal sphincter. Superior cholidocal sphincter will be there, and we also have inferior cholidocal sphincter will be there. Superior cholidocal sphincter and inferior cholidocal sphincter will be there. So this is sphincter of Oddi complex. Then we have something called as cholidocal cyst. In cholidocal cyst, here there is dilatation of the common bile duct is seen, which is congenital, and here there is dilatation of the common bile duct is seen, and this is congenital and most commonly seen in children, that too female children. Most acceptable hypothesis for this is abnormal pancreatico-bile duct junction. Abnormal pancreatico-bile duct junction abnormalities results in cholidocal cyst. Cholidocal cyst mainly arises due to abnormal pancreatico-biliary duct junction. So here there will be a common channel, long common channel will be there, which causes reflux of pancreatic enzymes and digestion of the bile duct wall, leading to dilatation. So in the cholidocal cyst, so first we have a classification called as Todani classification. So in the Todani's classification, we have 1A. In 1A, there is cystic dilatation of extrahepatic bile duct will be there. So in the extrahepatic bile duct, you will see cystic dilatation is seen. So this is 1A. Then we have 1B. In 1B, there is local segmental dilatation of extrahepatic bile duct will be there. In 1B, there is local segmental dilatation of extrahepatic bile duct will be there for 1B, and 1C, there is fusiform dilatation. 1B also local segmental dilatation only. Then in 1C, we have fusiform dilatation will be seen like this. In 1C, you will see fusiform dilatation of the hepatic duct, extrahepatic duct. Okay, this is type 1. 1A, 1B and 1C. 1A, you have saccular dilatation. 1B, you have focal segmental dilatation. 1C, you have fusiform dilatation. Then we have type 2. What is type 2? Type 2, you have diverticular dilatation like this. Sorry, this is also like this. I'll explain this again, Todani's classification. So according to Todani's classification, in the Todani's classification, we have 1. In the 1, we have cystic dilatation of the extrahepatic bile duct will be seen. In 1, you will see cystic dilatation of extrahepatic bile duct. There is cystic dilatation of extrahepatic bile duct will be seen in 1. Then you have 2. In 2, you will see diverticular dilatation of extrahepatic bile duct. You will see diverticular dilatation of extrahepatic bile duct will be there in type 2. Then type 3. Type 3, you will see intraduodenal dilatation. In type 3, you will see dilatation of intraduodenal dilatation of the common bile duct is seen in type 3. Then we have type 4. In type 4, we have type 4A. In type 4A, there will be dilatation, both intrahepatic and even extrahepatic dilatation will also be there in type 4. Both intrahepatic and even extrahepatic dilatation will be seen in type 4A. In type 4B, there will be multiple cysts involving the extrahepatic biliary duct. There will be multiple cysts will be there which are involving the extrahepatic bile duct. This is type 4B. Then we have type 5. In type 5, there will be multiple involvement in only intrahepatic but not extrahepatic. So this is type 5. Okay, type 5, there is multiple cysts involving the intrahepatic bile duct. That is type 5. So we have type 1A, type 2, type 3, type 4A, type 4B and type 5. Now in type 4A and also type 5 you should do liver transplantation because intrahepatic involvement is seen, whereas in type 4B, type 1 and type 2 you can do Rho and Y hepaticojejunostomy can be done. If it is type 3 then you have to do endoscopic sphincterectomy is done. Then if you see the clinical features, the patient presents with mass, pain and jaundice, that is intermittent jaundice is seen. Most common presentation is in less than 2 years of age, you will see presence of jaundice will be seen. In more than 2 years of age, you will see presence of abdominal pain will be seen in the patient. In less than 2 years of age, you will see jaundice. In more than 2 years of age, you will see that the patient suffers from abdominal pain. Then if you see the most common site of cholangiocarcinoma which develop is in the posterior wall of the cyst. If this is the anterior wall, it is the posterior wall. In the posterior wall of the cyst, you will see the most common site of cholangiocarcinoma. Then if you see the stones in the gallbladder, is called as cholelithiasis. Then if there are stones in the bile duct, then this is cholidocolithiasis. And if the stones are seen in the cyst, in this cholidocal cyst, if you see stones, then this is called as cystolithiasis. Stones in the cyst is called as cystolithiasis. Now, cholidocal cyst will increase the risk of the following organ manifestations. So, if you see the cholidocal cyst, will increase the organ malignancies of the following organs. It increases the organ malignancies of liver, gallbladder, then bile duct it increases, and it increases the organ malignancies of pancreas and also duodenum. So in cholidocal cyst increases the risk of following organ malignancies: liver, gallbladder, bile duct, pancreas and duodenum. Then Rho and Y hepaticojejunostomy. This Rho and Y hepaticojejunostomy procedure is the most commonly performed gastrointestinal reconstruction. Here jejunum is divided into proximal and distal limb, the afferent limb and the efferent limb. Distal limb is efferent limb. The length of the Rho and Y limb is 40 to 50 centimeters. Proximal end is anastomosed with the lower part of Rho and Y limb. The Rho and Y limb is pulled up and anastomosed with the hepatic duct. So first proximal part is anastomosed with the lower part of Rho and Y limb. Proximal part anastomosed with the Rho and Y limb, and the Rho and Y limb is pulled up and anastomosed with the hepatic duct. So let me draw this. So first we have, this is the liver and this is the stomach. And here you will first divide it here in the jejunum, and then this is the continuation part. Okay, now once you have divided it, next you will bring this part. You will bring this part here. This part is brought here. The proximal end is brought here, and it is actually anastomosed with the gallbladder. That is not gallbladder, also it is portal stump. It is anastomosed with the lower part. Here porta enters, you will anastomose it into the portal duct. Not portal, sorry. Bile duct, sorry. It is anastomosed into the bile duct, and then this part attaches here like this. Okay, so this is Rho and Y hepaticojejunostomy procedure. Then if you see the investigation of choice for cholecystectomy is MRCP. Sorry, investigation of choice for cholidocal cyst. Investigation of choice for cholidocal cyst is MRCP. So in MRCP, it is actually purely diagnostic procedure. Okay, in this you will make a T2 phase of MRI is taken, and it has two things. Okay, T2 phase of MRI is taken, and it can have either fast moving fluids can be seen. fast moving fluids or tissues can be seen, or fats can be seen, or you can also see slow moving tissues can be seen, like bile and pancreatic juice. If there is fast moving tissues like fast moving fluids, tissues and fats, then if it gives no signal, then it appears black. It is seen as black. If there is slow moving fluids like bile and pancreatic juice are seen, and if it gives high signal intensity, then it is seen as white. Okay, if first you will do T2 weight MRI. So once you do T2 phase MRI, if you see fast moving fluids, tissues and fats, and if they give no signal, they appear black. And if you do them, and if you see you have slow moving fluids, bile and pancreatic juice, slow moving bile and pancreatic juice, and if it gives high intensity, then it appears white. Now if you see MRCP is investigation of choice for, it is investigation of choice for obviously it is investigation of choice for Cholidocal Cyst. Along with that, it is also investigation of choice for CBD stones, and also it is investigation of choice for biliary stricture, MRCP. Okay, then MRI plus MRCP. MRI plus MRCP is investigation of choice for Cholangiocarcinoma. MRI plus MRCP is investigation of choice for Cholangiocarcinoma. Then we also have ERCP. This ERCP is both diagnostic and therapeutic value. It has both diagnostic and therapeutic value. Here we use a side viewing endoscope is used. Okay, MRCP is both ERCP is both diagnostic and therapeutic. ERCP is both diagnostic and therapeutic. Side view endoscope is used. Now in the side view endoscope you use it, and after reaching the ampulla, using the endoscope, both the bile duct and pancreatic duct are cannulated. So this is the, so using an endoscope, you will use an endoscope, and in the endoscope you will have a side view. Okay, so after reaching the ampulla, using the endoscope, both the bile duct and pancreatic duct are cannulated, and dye is injected to detect the stone and stenosis. Both this is cannulated, and you will inject the dye. Dye is injected to detect the stone or stenosis. Now this ERCP can also be used to remove the stone. So if you see any stone, so if there is a stone here, you can also put the endoscope here like this, and you can remove the stone also. So you can also put the stent mainly from distal biliary stricture. So first ERCP is used to remove the stone from distal part of the bile duct, and you should also put a stent mainly for distal biliary stricture. Then we have percutaneous transhepatic cholangiography. In percutaneous transhepatic cholangiography, this is both diagnostic and therapeutic value. This has both diagnostic and therapeutic value. It is used to remove the proximal part of the bile duct and intrahepatic duct. It is mainly used to remove the stone from the proximal part of the bile duct and intrahepatic duct, and it is used to locate the stent for proximal biliary strictures. Then we have to learn about CBD stones. CBD stones are also called as Cholidocal lithiasis. These Cholidocal lithiasis are present in 6 to 12% of patients with gallbladder stones. And these gallbladder stones are of two types. One, we have retained gallbladder stones, and we have recurrent gallbladder stones. One, retained gallbladder stones. Second, we have recurrent gallbladder stones. Retained gallbladder stones are actually detected within 2 years. They are detected within 2 years, whereas recurrent gallbladder stones, they are detected after 2 years. So gallbladder stones can be of two types. One, we have retained gallbladder stones, common bile duct stones. That is common bile duct stones, not gallbladder stones, sorry. Common bile duct stones are of two types. One, we have retained common bile duct stones. Second, we have recurrent common bile duct stones. Retained common bile duct stones are detected within 2 years of cholecystectomy. Recurrent common bile duct stones are detected 2 years after cholecystectomy. Now, these common bile duct stones are of two types. One, we have primary stones. Second, we have secondary stones. These common bile duct stones are of two types. First, we have primary stones. Second, we have secondary stones. These primary stones are actually formed inside the common bile duct. They are formed inside the common bile duct, and this the most common type of stone of primary stones is the brown color, and it is most commonly seen in developing countries. It is brown color stones seen in developing countries, whereas in secondary gallstones are formed in the gallbladder, and they are formed in the gallbladder and they slip out from the gallbladder into the common bile duct. Okay, they are the most common type of this common bile duct stone is we have cholesterol stone is most common type of secondary stone, and this is most commonly seen in the western countries. Cholesterol stone is most common and secondary stones are mainly seen in the western countries, whereas primary stones are mainly seen in the developing countries. The most common type of stone present in primary stones are brown color stone, whereas secondary stones most common type of stone present is cholesterol stone. Then if you see the lab parameters, increased ALP, increased gamma glutamyl transferase, and also increased 5-nucleotidase is the main lab parameters which are present in common bile duct stones. So in common bile duct stones, there will be increased ALP, increased GGT, increased 5-nucleotidase is seen. Then we have asymptomatic elevation. You will also see presence of asymptomatic elevation of gamma glutamyl transferase, and increased ALP is seen, and 5-nucleotidase is also seen. And here there is presence of jaundice is seen with or without complications. You will see presence of jaundice. So if you see what are the complications which you see from Cholidocal lithiasis, the main complications are there will be increased infections, there will be increased pancreatitis, increased cholangiocarcinoma is seen. So what is the gold standard for this? Cholidocal lithiasis, ERCP is the gold standard, but investigation of choice is MRCP is done. So how are you going to treat it? Treatment is you can do ERCP and you can remove the stone which is present, and maximum size of the stone that is removed by ERCP is 1.5 centimeter stone can be removed by ERCP. If the stone is more than 1.5 centimeters, then you should do cholidocotomy should be done. If the stone is 1.5 centimeters of the stone, you can remove it by ERCP. If the stone is more than 1.5 centimeters, cholidocotomy should be done. Then if there is distal obstruction is suspected. If you suspect any distal obstruction, okay, then you should do Duodenostomy is done. If you suspect any distal obstruction, then you should do Duodenostomy should be done. Then the next important is cholangitis. Cholangitis, the main mandatory principles of cholangitis are there will be in cholangitis you will see presence of obstruction and infection will lead to obstruction and infection of gallbladder will lead to cholangitis. So if you see the risk factors, in the risk factors the most common risk factor of cholangitis is presence of gallstones in the common bile duct. These are called as cholidocal lithiasis. So cholidocal lithiasis is most common, and there will be also formation of biliary stricture can also lead to cholangitis, and even cholidocal cyst can lead to cholangitis, and cholangiocarcinoma and worms, all these will lead to cholangitis. Now pathophysiology, the most common organism of cholangitis is E. coli is the most common organism, followed by Klebsiella is the most common organism. Now the infection reaches the systemic circulation and it will result in cholangiovenous varix and also cholangiolymphatic reflex. So here whenever the infection reaches the when the infection reaches the bile duct, okay, think that from the this is the liver, this is the bile duct, okay, this is the actual duodenum. Okay, now when the infection reaches the systemic circulation, this infection can reach the systemic circulation by cholangiovenous reflex. That is from this bile duct, the reflex can occur to the venous system and it can spread the infection. Okay. Similarly, there can be cholangiolymphatic reflex also, thus resulting in cholangitis. This mainly occurs whenever there is obstruction to the common bile duct by a stone. Okay, now when there is obstruction to the common bile duct by a stone, the common bile duct pressure will increase. Actually, if you see what is the common bile duct pressure, The common bile duct pressure is 10 to 12 centimeters of water is the common bile duct pressure. Now, what is the common bile duct pressure? Common bile duct pressure more than 25 centimeters of water. See, first, whenever there is a stone is there, the common bile duct pressure increases to more than 25 centimeters of water. This leads to the reflex back into the venous system and the lymphatic system. Then that is called as cholangiovenous reflex and cholangiolymphatic reflex. Then for cholangitis, you have something called as Charcot's triad. In Charcot's triad, the patient presents with pain, jaundice, and fever is seen in Charcot's triad. If you add shock and mental status to it, mental status changes to it, then we call something called as Raynaud's pentad. Then we call it as Raynaud's pentad. So here Charcot's triad is pain, jaundice and fever is Charcot's triad. Then Raynaud's pentad is a Charcot's triad with shock and mental status changes is called as Raynaud's pentad. So what is Charcot's triad? Pain, jaundice and fever is Charcot's triad. Along with Charcot's triad, shock and mental status changes together we call it as Raynaud's pentad. Then more than 50% of patients will have positive blood culture. More than 50% of patients will have positive blood culture also. Next, if you see the treatment, in the treatment you will have to put two large bore IV cannulas are put, and you will start the patient on IV antibiotics and IV fluids. Then once you give IV fluids, you should see whether there is any improvement or not. If there is no improvement, then you should do ERCP with stone extraction can be done. Even if with ERCP with stone extraction is not available, or if it is failed, then you can do percutaneous transhepatic cholangiogram with stone extraction and stunting. If this percutaneous transhepatic cholangiogram with stone extension is not possible, then you can do open biliary decompression can be done. So these are the main steps for management. Then how do you do open biliary decompression? Here first you will put an incision in the bile duct and then you will remove the stone. Once you have removed the stone, then you will insert a T-tube. Is inserted into the common bile duct. Okay, then you will do T-tube is inserted, and then T-tube cholangiogram is actually done at 7th to 10th day. Okay, and then this T-tube will retain for 4 to 6 weeks, and this T-tube will retain for 4 to 6 weeks, and then you can do percutaneous stone extraction is performed via a technique called as Burr-Henel technique. Via the Burr-Henel's technique, you can do percutaneous stone extraction can be done. Percutaneous stone extraction can be done via Burr-Henel technique. Then if you see the next important disorders are, we have autoimmune disorders. In the autoimmune disorders, we have primary biliary cirrhosis. For primary biliary cirrhosis, the antibody is anti-mitochondrial antibody. Then we have Graves' disease. In the Graves' disease, the antibody is thyroid stimulation antibody. Then we have Hashimoto's thyroiditis with anti-thyroid peroxidase antibody. Then we have pernicious anemia with antibody against the parietal cells. With antibody against the parietal cells, we have pernicious anemia. Then we have primary biliary cirrhosis. In primary biliary cirrhosis, this is the autoimmune disorder most commonly seen in females, and here anti-mitochondrial antibody is the most important autoantibody. The pathology is here you will see progressive destruction of intrahepatic bile ducts which are there, they get destructed. So the main diagnostic appearance is there will be florid duct lesion will be there with lymphocytic infiltration. There is florid duct lesion will be seen with lymphocytic infiltration will be seen, and granulomatous inflammation. Now the main diagnostic appearance is florid duct lesion will be there with lymphocytic inflammation and granulomatous inflammation. Now if you see clinical features, the patient has pruritus which precedes the jaundice, and there will be pruritus and fatigue will also be there. Pruritus and fatigue are the main characteristic symptoms. Pruritus becomes most bothersome especially in the evening, and this pruritus is associated with hyperlipidemia, xanthoma, xanthosoma and melanosis also. So what is the diagnosis? Diagnosis is by finding out this antibody which is anti-mitochondrial antibody will confirm the diagnosis. Then what is the investigation of choice? Investigation of choice is biopsy, and if you see what is the treatment, treatment is liver transplantation is the treatment for primary biliary cirrhosis. Then we have something called as primary sclerosing cholangitis. So what do you see in primary sclerosing cholangitis? Primary sclerosing cholangitis is most commonly seen in males with which here there are multiple strictures will be seen. So here you will see presence of multiple strictures both in intrahepatic and also in extrahepatic. You will see that there will be multiple strictures will be seen. Okay, it is associated mainly with HLA B8 and it is associated with HLA DR3. Okay, here you will see there is ulcerative colitis involvement will be seen. This ulcerative colitis will so almost in all the cases of ulcerative colitis, 70 to 80% of cases have primary sclerosing cholangitis, and in primary sclerosing cholangitis is actually seen in 5 to 6% of ulcerative colitis. So in all the cases of ulcerative colitis, 70 to 80% of cases have primary sclerosing cholangitis, whereas in all the cases of primary sclerosing cholangitis, 5 to 6% will have ulcerative colitis. So, if you see this ulcerative colitis, one important thing is smoking is protective in some diseases. Smoking is protective in ulcerative colitis, it is protective in primary sclerosing cholangitis, it is protective in Parkinson's disease and Alzheimer's disease. Smoking is protective. So, smoking is protective in ulcerative colitis, primary sclerosing cholangitis, Parkinson's disease and Alzheimer's disease. Then if you see the pathophysiology, in the pathophysiology, the target cell injury in primary sclerosing cholangitis is cholangiocytes. The main target cell is cholangiocytes are the main target cells. Okay, here there will be stricture formation will be seen in both intrahepatic and extrahepatic bile duct, and there will be onion skinning appearance will be seen on the cut section. You will see appearance of onion skinning, and there will be destruction of intrahepatic branches occurs, and whenever there occurs destruction of intrahepatic branches, you will see inside, you will see prun tree appearance will be seen because of the destruction of the terminal intrahepatic branches. Next, if you see the clinical features, the main clinical features are there can be asymptomatic elevation of gamma glutamyl transpeptidase is seen initially. Along with that, there will be formation of multiple strictures will be seen, and these multiple strictures will lead to increased cholangitis will be seen. There will be formation of multiple strictures leading to increased risk of cholangitis. CBD stones are seen, and also there will be acute pancreatitis is seen in these patients, and also cholangiocarcinoma is seen. So in multiple strictures, there will be formation of multiple strictures will be seen, which leads to increased risk of cholangitis, common bile duct stones, acute pancreatitis, and also cholangiocarcinoma. Now, if you see the investigation of choice in this is MRCP is the investigation of choice, and gold standard is ERCP is the gold standard. For bile duct, MRCP is the investigation of choice and ERCP is the gold standard. In the ERCP, you will see appearance of beaded appearance will be seen. In this, you will see appearance of beaded appearance or pseudo-diverticula will be seen in the ERCP. Okay, now if you see the treatment of choice is there will be liver transplantation will be seen, and also the main control of inflammation is high dose ursodeoxycholic acid will be seen. Is the main control of inflammation. High dose ursodeoxycholic acid is the main control of inflammation. Treatment of primary sclerosing cholangitis does not affect the course and prognosis of ulcerative colitis. Next, if you see the next important thing, we have bile duct injury. So in the bile duct injury, the incidence of bile duct injury in laparoscopic cholecystectomy. The incidence of bile duct injury in laparoscopic cholecystectomy is 0.3 to 0.85%, whereas the incidence of bile duct injury in open cholecystectomy is 0.1 to 0.2%. So there is more chances of injury is present in laparoscopic cholecystectomy when compared to normal open cholecystectomy. Most common injured part in the bile duct in laparoscopic cholecystectomy is mainly the proximal part of the bile duct is more commonly injured. The proximal part of bile duct is more commonly injured, and if you have to see the specifically, it is lateral wall of common hepatic duct is the one which is most commonly injured. Lateral wall of common hepatic duct is the one which is most commonly involved. Now, if you see the classification of bile duct injuries, bile duct injuries have one classification which we have is Bismuth classification. According to the Bismuth classification for bile duct strictures, we have type 1. So in the Bismuth classification of biliary strictures, we have 5 types of strictures. In type 1, we have common hepatic duct stump. Here if you see, this is the common hepatic. So if the injury is here, where the common hepatic duct stump is more than 2 centimeters, if the injury is present in such a way that the common hepatic duct stump is more than 2 centimeters, then this is called as type 1. Then we have type 2. In type 2 is if the common hepatic duct stump, if the common hepatic duct stump will be less than 2 centimeters. Common hepatic duct stump more than 2 centimeters, then that is type 1. Whereas common hepatic duct stump less than 2 centimeters, where the stricture is present mid stricture. Here the stricture will be present. Then we call it as type 2. When the stricture is less than 2 centimeters from the common hepatic duct, then this is called as type 2 or mid stricture. Then we have type 3. If you see type 3, in type 3 we have hilar stricture. So in this you will have hilar stricture will be said with intact confluence. You will see hilar stricture with intact confluence will be seen. So this hilar stricture is actually type 3. Okay. Then here the stricture is also high. This is called as high stricture. Then we have type class 4. In type 4 the hilar stricture with destroyed confluence. There is hilar stricture will be there, and there is destroyed confluence will also be seen. Hilar stricture is seen with destroyed confluence. The confluence here is also destroyed. Okay, even the meeting point of this is destroyed, but here the meeting point of this is even intact. So this is hilar stricture with destroyed confluence, which is type 4. Then we have type 5. In type 5 there is a stricture involving the aberrant right sectoral duct with or without involvement of common hepatic duct. There is just involvement of aberrant right sectoral duct here, but there is no with or without involvement of hepatic duct. So this is type 5. Then drawback of bismuth classification is there is no idea about intraoperative bile leaks. That is the main drawback of bismuth classification. Then we have Strasbourg classification. Strasbourg classification of laparoscopic bile duct injuries. So in this we have type A. Type A we have cystic duct stump leak will be seen. You will see the leak is present from the cystic duct. Here you have removed the cholecystectomy. So from the cystic duct, if leak is happening, then that is type A. Then type B. Type B is ligation and occlusion of right sectoral duct. So you have ligated it, and there is no leak in type B. There is just ligation and occlusion of the aberrant right sectoral duct is type B. Okay, occlusion of the aberrant right sectoral duct is type B. That is type B. Now you have type C. In type C there is transection. In type C there is transection in the aberrant right sector. Transection will be there without occlusion. There is no occlusion. You have just cut it. But if there is no occlusion, there is transection without occlusion of aberrant right sectoral duct is seen. So obviously you will see that there will be leaking occurs. Okay. Then we have in the type D. In the type D, these are all normal, but there will be a leak from the lateral wall of common bile duct. There will be a leak from the lateral wall of common bile duct occurs. This is type D. So this is type C, this is type D. Then we have type E is almost similar to the bismuth classification only. So this is Strasbourg classification of laparoscopic bile duct injuries. Then once there is bile duct injuries, what do you do? So for bile duct injuries, first and foremost you will control the infection by giving IV antibiotics, and then you will have to drain the biloma. You should give antibiotics and drain the biloma. Okay, and then you have two options. One, you can do USG guided or CT guided percutaneous aspiration is done, or you can insert a drain insertion or digital catheter insertion is done. Drain insertion or digital catheter insertion is done. So one is you can do either USG or CT guided percutaneous aspiration is done. Second, you can do drain insertion or digital catheter insertion is done. And after this you will have to do cholangiography should be done. Complete cholangiography is done by MRCP can be done. Okay, then after that, the definitive treatment, you have done MRCP. Now you know where the block is. Then you can do ERCP, with stunting can be done, or you can also do hepatojajunostomy. So if drain output is decreasing, then you should do observation. If any time, if this drain output is decreasing, you can just observe the patient. If drain output is increasing, then you can do ERCP, with stunting can be done. If the drain output is decreasing, then you can observe the patient. If drain output is increasing, then you should do ERCP, with stenting can be done in the patient. Then we have cholangiocarcinoma. So what do you see? What are the risk factors of cholangiocarcinoma? The main risk factors of cholangiocarcinoma is cholidocal cyst. Then we have choledocholithiasis. The main risk factors are choledocal cyst, choledocholithiasis, primary sclerosing cholangitis, ulcerative colitis, cirrhosis, clonarchis sinensis, and Opisthorchis viverrini. Clonarchis sinensis and Opisthorchis viverrini. Then we have hepatitis B virus, hepatitis C virus, asbestosis, and also we have nitrosamines. Nitrosamines, dioxin is seen, and also we have diabetes mellitus or obesity or OCPs, and smoking is seen. Then you have thorotrast and isoniazid can be seen. So if you see the risk factors of cholangiocarcinoma are choledocal cyst, choledocholithiasis, primary sclerosing cholangitis, ulcerative colitis, cirrhosis, clonarchis sinensis and Opisthorchis viverrini, hepatitis B virus, hepatitis C virus, asbestosis, nitrosamines and dioxin, and diabetes mellitus, obesity, oral contraceptive pills and smoking, thorotrast and isoniazid. These are the main risk factors of cholangiocarcinoma. Then if you see what is the most common site of cholangiocarcinoma, hilar cholangiocarcinoma is the most common site of cholangiocarcinoma. Then this hilar cholangiocarcinoma is also called as Klatskin tumor is hilar cholangiocarcinoma. Then what about the similarities? The similarities between cholangiocarcinoma and common bile duct carcinoma is gallbladder carcinoma. The cholangiocarcinoma and gallbladder carcinoma, both these are actually adenocarcinoma. In both these carcinoma, embryonic antigen will be increased and it is a non-specific marker. In both these, CA19-9 will be increased, which is a specific marker. In both these, you can do chemotherapy can be done, which is gemcitabine, and cisplatin can be used for chemotherapy. In both these will have common histological features like diffuse infiltrating variety, which is most common, and it also includes nodular or mass forming variety and papillary variety are seen. This papillary variety is actually the best prognosis. So these are the main differences between the cholangiocarcinoma and gallbladder carcinoma. Then if you see the clinical features, in the clinical features, the main presentation is presence of progressive jaundice is seen in the patients. Progressive painless jaundice followed by weight loss is seen. The symptoms are anorexia, fatigue, pruritus, presence of or passage of clay colored stools are seen. Then we have Courvoisier's law. In Courvoisier's law, this occurs mainly in the case of obstructive jaundice, mainly due to the stone disease. Okay, obstructive jaundice in stone disease. In this, the gallbladder is not palpable. Obstructive bladder in stone disease, gallbladder is not palpable, and this gallbladder becomes shriveled and fibrosed. Okay, it becomes shriveled and fibrosed due to chronic inflammation. In case of obstructive jaundice, and if gallbladder is not palpable, then gallbladder becomes shriveled and fibrosed. Now, if gallbladder is palpable, in the case of obstructive jaundice, if gallbladder is palpable, then it is most commonly due to periampular carcinoma. Okay, if the patient has obstructive jaundice and if gallbladder is not palpable, then it is mainly due to the if gallbladder is not palpable, then it cannot be due to stones. That is number one. Number two, if gallbladder is palpable due to obstructive jaundice, then it is due to periampular carcinoma. Then, if you see the exceptions of the Courvoisier's law, exceptions are we have double impaction of stone. One exception is we have double impaction of the stone. In the double impaction of the stone, we have one stone is present in the cystic duct and we have second stone which is present in the common bile duct. First stone is present in the cystic duct and we have second stone which is present in the common bile duct. And also we have mucosine. So this is the exception of the Courvoisier's law. Exceptions of Courvoisier's law is one, double impaction of stone is present, one in the cystic duct, second in the common bile duct, and you will also see presence of mucocele is seen, and you will see presence of cholangiohepatitis. Even the one more exception is if there is oriented cholangiohepatitis, or if the stone is impacted in the ampulla of Bladder, so that is also an exception. Then we have ampullary and periampullary carcinoma. So if you see ampullary and periampullary carcinoma, first in the ampullary carcinoma, here the malignancy is arising from the ampulla itself, then we call it as ampullary carcinoma. In periampullary carcinoma, if it arises around 2 centimeters from the ampulla, then we call it as periampullary carcinoma. Then malignancies which are present in the periampullary region are, so this is the common bile duct, and to this even the pancreatic duct will come and bind. Okay, and both these will open into the second part of duodenum. So malignancies which are, so that this is the ampulla, so the area around it, so this is 2 centimeters from area around the ampulla is called as periampullary carcinoma. Here in the malignancies which are seen in periampullary carcinoma are ampullary carcinoma, carcinoma head of pancreas will be seen. Obviously there will be head of pancreas here, carcinoma head of pancreas, and distal cholangiocarcinoma and also duodenal cholangiocarcinoma are the best prognosis. Ampullary carcinoma, carcinoma head of pancreas, distal cholangiocarcinoma and duodenal cholangiocarcinoma are the best prognosis in this case patient. Investigation of choice is MRI and MRCP. Investigation of choice is MRI, MRCP followed by CECT is the investigation of choice. Then if you see in the CECT, the main complication is you will see increased risk of hepatorenal syndrome is seen in these patients. In these patients, you will see increased risk of hepatorenal syndrome is seen. So investigation of choice is MRI plus MRCP is the investigation of choice which is more common than CECT. And in the CECT, you will see presence of increased risk of hepatorenal syndrome will be seen. Then if you see the management, in the management first we can do hilar. If there is hilar cholangiocarcinoma, in such case you should remove the CBD resection should be done, and also you should do routine caudate lobectomy should be done, and also you should do lymphadenectomy should be done. So if there is hilar cholangiocarcinoma, common bile duct resection with routine caudate lobectomy and lymphadenectomy should be done. If there is distal cholangiocarcinoma, then you should do pylorus preserving Whipple's procedure should be done. If there is distal cholangiocarcinoma, pylorus preserving Whipple's procedure should be done if there is distal cholangiocarcinoma. Then for advanced metastatic disease, if advanced disease and metastatic disease, in such cases you should give chemotherapy, that is palliative chemotherapy should be given. This palliative chemotherapy contains gemcitabine and cisplatin should be given. Gemcitabine plus cisplatin is the palliative chemotherapy which is given for these patients. Then we have hemobilia. So what is hemobilia? Hemobilia is actually if there is blood in the bile duct, then we call it as hemobilia. Presence of blood in the bile duct is hemobilia. So what do you see in hemobilia? The most common cause of hemobilia is trauma or iatrogenic trauma can also be there, especially in percutaneous transhepatic cholangiogram can lead to hemobilia. It can occur due to gallbladder stones. Then if you see the clinical features, in the clinical features we have something called as Quincke's triad is present, or we have Sandblom's triad. Quincke's triad or Sandblom's triad. In this Quincke's triad or Sandblom's triad, you have three. One, we have GI hemorrhage will be seen, and you have clot colic will be seen, and you have jaundice. So in the Quincke's triad, you have three things. One, you have GI hemorrhage, then clot colic, and jaundice is the thing which you see in Quincke's triad. Then because of this bleeding will reach the lower GI tract and it will manifest in the patient as melena, which is seen in 90% of cases. And if there is minimal bleeding, even minimal bleeding can cause melena of 40 to 60 ml melena can occur. Then if you see the investigation, the main investigation is you can do upper GI endoscopy can be done, which is the first investigation which is done. And the investigation of choice for hemobilia is angiography is the investigation of choice for hemobilia. So if you see the treatment of hemobilia, you can do conservative management is done in most of the patients, along with angiography, and embolization is done in rest of the patients in whom conservative management is not possible. Next, angiography and embolization if not available, then we should do open surgical ligation of the bleeding vessel should be done by using this with hemobilia.
Thank you, and thank you for watching.